going to begin with the learning objectives for this talk. I'm going to talk about first the epidemiology of drug allergies. Hopefully you all can hear me. So I'm going to talk about the epidemiology of drug allergies and the public health burden of the same. We're going to talk about the types of adverse drug reactions. We're going to go over some newer definitions that came out in the last 5 years or so. We're going to talk about the management of antibiotic allergies, focusing on type 1 hypersensitivities because this is the most common cause of referral to our clinic. And then we're going to talk about the COVID vaccine allergic reactions. The data regarding this is rapidly evolving, but I will talk about what we know at this point. I have tried my best throughout this talk to include just pediatric data, but there's some which is combined from the adult and the pediatric population, and that is because the principle and the concept is essentially the same regardless of the age of the patient. It's just the nature of the field. Allergy is a combined, and immunology is a combined field for this reason. So with the epidemiology of drug allergies, we all know that antibiotic allergy is a huge, or antibiotic allergy labels, I should say, is a huge public health burden in our society, regardless of the age of the patient. It can be estimated that at least 5 million children in this country are labeled with penicillin allergies. We now understand with a lot of overwhelming data that a lot of the cutaneous symptoms that are interpreted as drug allergy are, especially in the pediatric population, are infectious or due to a drug virus interaction and not really true drug hypersensitivities. Antibiotic allergy labels are common, especially penicillin allergy. It can be estimated that 15% of the population has been labeled with a penicillin allergy in most populations. Cephalosporin allergy is seen in 1 to 2% of most populations, and this is increased in females and then subpopulations with frequent antibiotic use. So in the pediatric population, we see this mostly in cystic fibrosis patients. And then Bactrim and sulfa allergy is seen in 3 to 5% of most populations, and then this is also seen in patients with immune deficiencies, transplant, oncology patients, etc. But why do we care so much about drug allergy labels in patients' charts? Well, it can be estimated that 75% of penicillin allergy labels are acquired in childhood, and it's acquired by 3 years of age. Most labels are inaccurate. It can be, so whenever you see a drug allergy label, it could be reflective of intolerances, side effects, family history. Very rarely is it a true drug hypersensitivity. 15% of adults end up, because of this, with penicillin drug allergy labels in their chart, when less than 5% are actually labeled, are actually true hypersensitivities. Even true IgE-mediated allergies are essentially fade over time, and more to come on this in subsequent slides. The label can become a greater liability than the risk of a reaction. So what happens when patients are labeled with drug allergies and they're really not true hypersensitivities? There's a pressure prescribing of second and third line antimicrobials, increase and inappropriate antibiotic selection, increased mortality risk, delay the onset of inappropriate antibiotic therapy, increased treatment failures. Huge issue in this population is multi-drug resistant infections, and all of the above overall leads to higher healthcare costs and longer lengths of stay. When we address this, especially in the pediatric population at an early age, patients are just safer. There's an avoidance of bad outcomes in general, and most importantly, there's it's cost effective and there's reduced healthcare expenses. In the pediatric population, especially when children are tested and actually undergo drug challenges and drug challenge. I will use the term drug challenges throughout this talk, and what that means is I give the patient the drug in the clinic or in the inpatient setting and see if they react. And there's more and more evidence coming out that greater than 90% of the patients are able to tolerate the antibiotic. We're going to go over a little bit about the classification of adverse drug reactions. So you all may have learned in medical school or even in residency. Initially, it was called type A and type B reactions, which is predictable and unpredictable. We are moving, as our mechanistic understanding of adverse drug reactions improves, we have moved away from those definitions, and now we have classified this into on-target and off-target adverse drug reactions. On target are essentially predictable because of the known therapeutic and pharmacological actions of the drug. C. diff-associated colitis is a classic example of this. Off-target adverse drug reactions are non-immunologically mediated, broadly classified, and then immunologically mediated. So non-immunologically mediated is basically when the drug interacts with a non-immune cell receptor, for example, aminoglycoside-induced ATN is a classic example where the antibiotic interacts with a non-immune cell receptor, causes apoptosis via the intrinsic pathway of mitochondrial apoptosis, and then not immune cell receptor interaction is basically when the drug interacts with a receptor called MRGPRX2. So MRGPRX2 is very famous in the allergy world. You all may have heard of vancomycin, red man syndrome, radiocontrast media, all of those drugs and fluoroquinolone actually interacts with this receptor MRGPRX2 and causes mast cell degranulation or release of mast cell mediators independent of IgE. So these are non-IgE mediated reactions. And this is why you can pre-treat vancomycin, pre-treat radiocontrast media reactions, and prevent that IgE mediated process. True IgE mediated allergies, you cannot pre-treat them and prevent the reaction. So immunologically mediated hypersensitivity reactions. So this is your classic type 1, 2, type 4 hypersensitivity reactions. Here they have broadly defined it into antibody and pure T cell mediated reactions. Your antibody mediated reactions are type 1 to type 3, so IgE mediated, so penicillin, angioedema, or any IgE mediated process comes under this. And then pure T cell mediated would be your DRESS, SJS, TEN, etc. So throughout this talk, I will be concentrating on the antibody mediated reactions or the IgE mediated reactions. The management of DRESS, SJS, and TEN would be an additional 30 minutes and beyond the scope of this talk. So this is an interesting chart, and this is what I use to convince, especially my older adolescent and teenagers who are not convinced that they've grown out of their penicillin allergy. So along their along the x-axis is the time between the penicillin reaction and testing, and along the y-axis is the predicted probability of positive penicillin skin testing. And what this graph shows is that even if you essentially had an IgE-mediated process or a drug reaction or had true anaphylaxis, more likely than not, and you tested positive, which most of those patients do, more likely than not, you have grown out of your allergies over the years. So if a 10-year-old comes to me and has a non-specific, even if they had like an IgE-mediated process, like anaphylaxis when they were less than a year old or 2 years old, more likely than not, they have grown out of it at this point. And this is just for penicillin allergies. So this is what I do whenever any patient comes to us with any history of an allergic reaction to any drug. So this is not just for penicillin. what we are essentially trying to do is making sure they do not have the highest high-risk reactions, and that is SJS, TEN, AGEP, or acute generalized exanthematous pustulosis, serum sickness, things like that. These patients cannot undergo testing. These are usually lifelong reactions, and they usually will have it for the rest of their lives, and you have to avoid it. For high-risk reactions, which is consistent with anaphylaxis, depending on the time, these patients will be eligible for skin testing, and possibly a challenge if the skin testing is negative. I highlighted the low risk history because greater than 90% of the patients with a drug allergy will have a history, will have a low risk history. In kids, we usually see a rash that started several days after starting an antibiotic, and then lasting for several days even after switching the antibiotic. And that's greater than 90% of those drug reactions. Even urticaria lasting for several days is a low risk reaction. The other low risk histories are family history with the permission of the family. If they just have a family history, I just counsel them and I remove the drug allergy from their chart. And then known tolerance of the penicillin. They're very easily in older teenager patients or teenagers or adolescents. All I do is look at the medication history, and a lot of the time I do find that they've taken Augmentin or something, and then I would just remove that allergy out of their chart, like bypassing skin testing and drug challenge altogether. I did want to talk about non-immediate, the benign reactions, so not the T-cell mediated reactions. These are all exanthems. They are not IgE mediated. They do not progress to anaphylaxis. And very rarely they can progress to the severe cutaneous adverse drug reactions, which is DRESS and SJS and TEN. I do want to put a star on serum sickness-like reactions, especially in the pediatric population, because there is some data coming out now that a lot of the time this is, again, infectious, not drug induced, and they could be challenged at some point to that drug later on in life, and they may not need to completely avoid it. This is a picture that I see all the time in parents' phones. Again, virally induced, usually occur a few days into the course. It is usually itchy. Patients call it hives all the time. They usually start in the trunk and spread to the extremities. There's no risk for anaphylaxis. If the patient has been previously sensitized, it can occur after a shorter period, so like 6 to 12 hours. If it's a first exposure, it occurs after several days. Again, it does not usually progress into T-cell mediated reactions like DRESS, SJS, TEN, but they can have very mild eosinophilia. I thought this was an interesting chart, and this is unpublished data from Cincinnati Children's, and they looked at the children presenting to the ED with amoxicillin-associated rash, and if you look at the urticaria, you'll see that so presentations for urticaria increase when viral infections are seen in kids, most commonly in the winter time anyways. So I thought this was interesting, and it shows you that a lot of the time it's an infectious presentation rather than the drug itself. So is there evidence to bypass skin testing for penicillin allergies? So this is just for penicillin allergies in children. Lots of evidence coming out. The evidence is overwhelming. So this is only for low risk reactions. So as long as they have a low risk history, you can go ahead and not skin test them and just give them the drug. And a lot of the time, as you can see, greater than 90% of these patients actually end up being delabeled. And this list is not exhaustive, and it was done in various settings, like inpatient settings, in the emergency room, primary care offices. Our goal as allergists is to have healthcare workers in different settings be able to risk stratify and bypass that referral to the allergist in general, and to be able to just do this in the clinic. And this is just for penicillin allergies. For the other antibiotic allergies, the data is still coming out, but I think it's all moving in that direction. So how do we skin test these drug allergies? When you refer patients to an allergist's office, the skin testing we do is only for IgE-mediated hypersensitivities. For T-cell mediated reactions, there are various things that you can do, but this is largely, I wouldn't say experimental, but research-based in huge drug allergy centers across the country. So this is what a skin test looks like. H is the histamine, which is a positive control. S is saline, which is the negative control, and these are components or determinants of penicillin. This is what a positive test looks like. And then if the histamine is not reactive or the saline is reactive, you essentially cannot read the test, so they're indeterminate skin tests. So a few caveats about cross reactivity, because we get this question a lot. The tolerance of a cephalosporin in a patient with a penicillin allergy does not rule out a penicillin allergy. The tolerance of, the other way is also true. The tolerance of a penicillin in a patient with a history of cephalosporin allergy does not rule out a cephalosporin allergy. It was, the initial thought was it was because of the beta-lactam backbone that there was cross-reactivity between penicillin and cephalosporins, but now we know that it is due to the cross-reactivity between side chains, and I will show you a diagram on this. Specific patients, like I talked about, are excluded from penicillin skin testing, so T-cell mediated reactions, they're not eligible for skin testing. And this is really important whenever I do a challenge in the hospital, in the inpatient setting or the outpatient setting. I make sure the family knows that the only thing we're trying to rule out is immediate hypersensitivity reactions or type 1 hypersensitivity. Are they going to get a benign rash tomorrow, 24 to 48 hours later? I cannot rule that out with this challenge. I also preface it by saying, are they going to get a severe cutaneous adverse drug reaction like SJST and DRESS? Again, you cannot rule that out with a single dose challenge. Most of the time, greater than 90% of the patients end up doing well. We wouldn't be doing the challenge if they were high risk. So, but it's something that patients should be aware of. So this is the cross-reactivity chart. This is the penicillin, this is the beta-lactam backbone, and the cross-reactivity between penicillin and cephalosporins is due to these side chains over here. And as you can see, penicillin, especially for amoxicillin, if the patient truly has an IgE-mediated process and you're suspecting an IgE-mediated process for amoxicillin or augmentin, really the only drugs that they should be avoiding are these drugs, and Keflex falls under that as well. Similarly, with ceftriaxone allergy or cephalosporin allergy, if a patient comes to me with a ceftriaxone allergy and I can't skin test them right away, these are the only drugs that I tell them to avoid. I do not tell them to avoid Keflex, for example. That being said, there have been reports of cross-reactivity across the beta-lactam family, but this is so rare that when it does happen, it's reportable. It's very, very rare. So quick recap on this section. If a patient comes in with an evaluation for an evaluation of a drug allergy, what we primarily do is risk stratify. If they have a low risk history, I go ahead and give them the drug in office, so a single or graded oral challenge. If they have a high risk history, and a high risk history which is consistent with anaphylaxis, then we skin test, usually prick and intradermal. If this is positive, then I tell them to avoid the antibiotic and structure-related drugs. And then I do want to say that, if a patient is admitted in the hospital with a high-risk history of anaphylaxis and the patient absolutely needs the drug, since we don't skin test in the hospital, this is when we would do desensitization. So desensitizations aren't for all patients with penicillin allergies. It's only for a high-risk history. Most patients come under this category, so we are able to just give them the drug in the hospital, monitor them, or in the office, monitor them, and then remove that drug from his or her chart as an allergy. So if they skin test negative, again, they qualify for a single graded oral challenge. Testing is not recommended for severe cutaneous adverse drug reactions, and this is a lifelong thing. You have to avoid the antibiotic and structure-related drugs. Okay, so this brings me to our next section about SARS-CoV-2 vaccine allergic reactions. Obviously, this is reported and pulled from adult data, mostly in healthcare workers. The data in this is rapidly evolving. I mean, it changed even 2 weeks ago. So this is what we know right now, but hopefully it is enough for you all to counsel your patients, especially the highly allergic atopic kids. So the two vaccines that I'm going to talk about and the ones that where allergic reactions have been reported are the Fisa and Moderna vaccines. As you all know, these are mRNA vaccines, and they produce antibodies to the viral spike protein. Why is this important? Vaccine allergic reactions can cause vaccine hesitancy, especially when this was reported first in the UK and then in the US. It was all over the news, and I definitely had families who were concerned about getting these vaccines because their kids were allergic as well, and it was all over the news that they were highly allergic people who carried EpiPens and things like that. Vaccine adverse reactions can cause vaccine hesitancy. Kids are a huge part of the general population, and we really need to address the issue of vaccine hesitancy in our community. So this was the initial report, and I got this from VAERS, and this was initially reported in December when it was given to healthcare workers. So these are all healthcare workers, and as you can see, most of them are females, had some kind of history, atopic history. Most of them reacted within 15 minutes, which is where that 15-minute wait from the CDC came from. They were treated in various settings. All of them received Epi. Most importantly, all of them were discharged home and they recovered. Brighton level scoring system is a scoring system for anaphylaxis. So 1 and 2 means that they met pretty good criteria for anaphylaxis. 3 and 4, not so much. So all of these patients met criteria for anaphylaxis, and they received Epi, and all of them were discharged home and they recovered. And most importantly, most of the allergic reactions so far have been reported after the first dose. So if they tolerate the first dose, more likely than not, they'll do okay for the second dose. And this is the biggest study that was done looking at the patients with a self-reported allergic reactions, and this was done by the fellows actually at Mass General and at Boston Children's. They looked at 64,900 healthcare workers that received either Pfizer or Moderna. And out of 64,900, 1,300 of those patients actually self-reported allergic reactions. But when they actually went ahead and looked at who met criteria or clinical criteria of anaphylaxis, only 16 out of those 1,300 actually met criteria. And this is a different NIAID criteria of anaphylaxis. Only 16 patients out of 1,300 actually met criteria. Self-reported allergic reactions were slightly more in Moderna than they were in Pfizer. And similar to the initial reports that came out, most of these patients, again, were female, had history of allergic reactions or anaphylaxis. 15 out of 16 of them actually started reacting within the 30 minutes period, which is why patients with allergies in general are required to wait those 30 minutes. And one patient actually ended up in the ICU, but only one out of that 16 had elevated tryptase. And as you all know, tryptase is a marker of mast cell degranulation. So if it's elevated, it is consistent with anaphylaxis. So only 1 out of 16 had elevated tryptase. So take-home points on the previous study. Greater than 64,000 patients receiving Pfizer and Moderna. Majority of them, 98% of them, had no symptoms. 2% had mild allergy symptoms, itching, rashes, hives, swelling. Anaphylaxis occurred in 2.47 out of 10K vaccinations. Allergy symptoms were slightly more in Moderna than they were in Pfizer, and again, this is self-reported. And only one patient had elevated tryptase. One patient did require the ICU, but most importantly, all of them recovered. So why are there a lot of self-reported allergic reactions? And this is what, me as an allergist, whenever I try to evaluate drug allergies or if there's a drug challenge going on in my clinic, I always try to see what the differentials are and what else it could be. Especially for vaccine allergic reactions, since it is an injection, a lot of the time we see vasovagal reactions. So vasovagal reactions presents with pallor, bradycardia, and hypotension. In anaphylaxis, we tend to see more flushing than pallor, and along with hypotension and tachycardia. Vocal cord spasm is a big one, especially in adolescent and teenagers. And then, of course, most commonly, it would be anxiety or panic attacks. So whenever you're assessing allergic reactions to vaccines, things that you may want to make, changes that you may want to make in your practice is to recognize anaphylaxis, but also know that there's a huge barrage differential for anaphylaxis. Carefully record vital sign, physical exam findings, skin findings. If you are thinking about referring to your friendly neighborhood allergist, images are so useful for us. Obtain tryptase within 90 minutes. The earlier, the better, but you can even wait after 4 hours, up to 4 hours after the onset of the reaction. And this is also very helpful in evaluating for anaphylaxis. Review the timing of immediate reactions. True anaphylaxis occurs within an hour, so if it happened delayed, it's less likely anaphylaxis. And if the reaction occurred after the first dose, weigh the risk of receiving the second dose versus being inadequately vaccinated. Motivated families will want that second dose and will be motivated to get that second dose regardless of how they reacted to that first dose. And refrain from calling patients allergic. patients tend to hold on to these terms and be attached to it. And please refer again to your allergist rather than them allergic, because we can help facilitate the safe administration of the vaccine. And this is the biggest this is the biggest limitation for at least allergists in the community who are evaluating these allergic reactions, is actually because when it was coming out in healthcare workers, vaccines weren't as available to obtain in order to test. So if you have a patient who had an allergic reaction to the vaccine, and now that there's actually a surplus of vaccines, it should be easier from here on out for us to test. So if you could obtain the vial for us, that would be very, very useful. So these are the active and inactive ingredients in Pfizer and Moderna, and the ones that I want you to pay attention to is the polyethylene glycol component, and also neither vaccine contains egg gelatin, latex, or preservatives. So this is the potential culprit, is polyethylene glycol. What is polyethylene glycol? It's Miralax. So if anyone comes to our clinic with a history consistent with polyethylene glycol allergy, this is what we use to test you. PEG allergy is very rare. It's rare even in the adult population. It's in a wide range of medications such as bowel prep, cosmetics, eye drops, etc. In kids, it's mostly seen in case reports to injectable medications, biologics, chemo, things like that. Again, it's only available, it's only reported in case reports because it's so rare. So I did want to talk about a case that I was involved in fellowship, because this is the typical presentation for a PEG or polyethylene glycol allergy. It is characteristic because it gets worse on repeat exposure. So this particular patient was a 58-year-old who was a paint department manager. And 3 years prior, and this is how we commonly see it in adults, is that they get their depot shot for the arthritis. It's a knee injection which contains PEG. And his reaction 3 years ago was mild, improved with antihistamines. 8.5 months prior, since he is involved in the paint industry, he had pruritic swollen hands on exposure to paint. And then finally, when he got bowel prep for his colonoscopy, he started developing shortness of breath, angioedema, and hypotension, requiring an epidose, but he was just monitored in the ED. And then 1 month prior to referral to our clinic, he actually ended up having a myocardial perfusion scan that contained pegylated product. This was his more severe reaction, ended up in the ICU on an epi drip. And PEG is in a lot of products, myocardial perfusion scans, even ultrasound gel contains PEG, and we've seen reactions to that as well. And this is what the skin testing look like in kids. We do something very similar. We just test essentially just to Miralax different concentrations and whatever vaccine or injectable drug that they reacted to. I did want to show you all this because as pediatricians, you all may be interested to know that PEG and polysorbate 80. So polysorbate 80 is a monomer of PEG, and that is present in a whole host of childhood vaccines. So more likely than not, your patient has already received it or gets it every year from the flu vaccine. So PEG itself is present in Pfizer and Moderna. Polysorbate 80 is present in Johnson & Johnson. And there's anecdotal evidence right now that even patients who have history of severe allergic reactions to PEG actually can tolerate the Johnson & Johnson vaccine because that contains polysorbate 80 and not PEG. So this is the current evidence, the most evidence we have right now for PEG allergy and COVID-19 vaccines. This was also done by the Boston group. They looked at 16 high-risk or employees with high-risk allergic reactions to PEG, either the injectable form or the oral form. So 8 out of those patients who had severe allergic reactions to an injectable form of PEG or polysorbate 80, 7 out of 8 of them actually had tolerated the first dose of Pfizer, Moderna, or Johnson & Johnson. The star is for one patient that had not received the first dose yet at the time the study was published. And 4 patients who had a history of severe allergic to oral PEG, so Miralax, 3 out of 4 of them actually ended up tolerating Pfizer. 1 patient actually ended up testing positive to PEG, but they ended up, like I said, being able to tolerate the Johnson & Johnson vaccine. There were 3 patients who actually ended up having a severe allergic reaction to any kind of injectable that did not contain PEG or polysorbate 80. And again, all 2 out of 3 were able to tolerate Pfizer, and one of them, again for the star, is the one that had not received the vaccine yet. So take-home points from this study: 16 high-risk patients were evaluated. Only one of them who had a history of severe allergic reaction to oral PEG tested positive to PEG and actually ended up receiving Johnson & Johnson safely. 4 out of 16 actually ended up receiving the other vaccines safely. And remember, 2 out of that 16 had not received the first dose yet, and that's why that wasn't included. So this came out a couple of weeks ago, actually, and this was again reported by the same group. And this is what allergists across the country are doing to evaluate these patients. So basically, if you do not have a history of anaphylaxis or don't have a history of any of the components of PEG, you are eligible to all of the COVID-19 vaccines. And here they suggest only if you have a history of PEG and polysorbate allergy do they even have you refer to an allergist and not take any vaccine. If you have possible PEG allergy only, you are eligible for the Johnson & Johnson vaccine with a 30-minute wait. And if you are only allergic to, or you have a history of an allergy to polysorbate 80, you're essentially still eligible to all COVID-19 vaccines, especially since a lot of the pediatric population, I think, will come under this category, that they essentially tolerated polysorbate 80 after the COVID-19 vaccine. If you have not tolerated it, they still say that you're okay to receive all COVID-19 vaccines and maybe a non-urgent allergy consultation after vaccination. I did want you all to be aware of some delayed cutaneous reactions, especially to the Moderna vaccine. This particular patient, again, was reported by the Boston group. It was a 16-year-old patient that came to you with a history of allergic reaction to the vaccine, received Moderna 1 week ago, did well in the 15-minute observation period, had mild arm pain and headache in the first few days, completely resolved, but around 1 week into the course developed a red swollen arm. And this is what was reported. So they essentially do well that initial period, and then 1 week later they developed this delayed large local reactions. And this was reported in the Moderna trial as well. So now there's more and more data that there are some delayed cutaneous reactions to SARS-CoV-2 vaccines. This is data from the COVID-19 International Dermatology Registry and was talked about at the American Academy of Dermatology meeting last month. There were 414 individuals who developed cutaneous reactions after Moderna, more than they did with Pfizer, and they were all delayed. There were large local reactions, urticaria, and mobiliform eruptions. Delayed reactions, like I talked about, occurred about 1 week later. Urticaria started about day 3, was diffuse arms, trunk, and legs. And the mobiliform rash was also started around day 3. All reactions occurred mostly in females. They all ended up getting their second dose, and only 43% recurred after the second dose. And none of these are predictors of anaphylaxis or any kind of immediate hypersensitivity reactions. So more information about COVID-19 vaccine allergic reactions to come in the following months. NIAID has announced a new clinical trial looking specifically at allergic reactions to only the Moderna and Pfizer vaccines. We just do not have enough data for Johnson & Johnson yet. Right now, they will only include adults because this is what because these are the patients that have reported allergic reactions, and if this is an issue in kids as well, 12 and 15, now that it is being given to this patient population, they will start introducing to the population as well. This is taking place across 35 academic drug allergy research centers across the United States. It will determine patients who are highly allergic or have mast cell disorders who are increased risk for anaphylaxis. So these are the patients that will be included in the trial. And then it will look at various genetic patterns and other factors that determine the risk of such allergic reactions. So stay tuned on this. And with that, I will take any questions that you all have. And please feel free to email me with any questions as well. Let me stop sharing.
Thank you for the presentation. I have a question about that adult patient that you mentioned who ended up going to the ICU. By any chance, do you recall whether a troponin had been done or any heart imaging? There are now 3 cases at Yale New Haven and 2 from Boston, where after second microRNA vaccines, positive spike protein, and evidence of myocarditis with elevated troponin, but fairly quick recoveries, being treated as, quote, mild. So they got steroids and a whole lot of other stuff, but they recovered. I'm wondering if they were PEG reactions like your adults.
So the one patient, interestingly, it was my colleague that evaluated that patient. It was a healthcare worker, actually, who she was a nurse practitioner who worked in like the oncology department, and she was, as you recall, there was a patient around in Alaska. It was after the first dose. So I don't think it was that patient, and that patient she completely recovered, and actually that particular patient ended up getting Moderna and doing well because she was super motivated, and she actually tested positive for PEG as well, but ended up getting Moderna. So I don't think that was the same patient. I'm not aware of her getting myocarditis. I'm sure I would have heard otherwise. Any other questions? I can't really see the chat. Please clarify at the end if a viral-induced rash is there's a previously sensitized component or just related, or is that related to antibiotic-induced rash? That is just related to the antibiotic-induced rash. So previously sensitized, what I mean is previously sensitized to the antibiotic itself. And then, do the delayed reactions correlate with seropositivity or evidence of prior infection at the time of vaccination? Are you talking about the delayed reactions to the delayed cutaneous reactions, Dr. Marshall? Oh, the delayed cutaneous reactions. I am not evidence of prior infection at the time. No, they did not comment on that from the evidence that I read. They didn't comment of if it correlates with seropositivity or not. And then can you comment on the reactions of COVID-19 with dermal fillers? I do not know. I don't know about any correlation between dermal fillers and allergic reactions to the vaccines. Yes, hopefully not too many kids, but you never know these days in kids with dermal fillers. Any other questions that I can take?
All right, thank you, Dr. Vathodi. If there are any further questions, please reach out to Dr. Vathodi via email. I'll include her email in the chat. Thanks again.